All right, so we'll open up our last session for the conference, and we'll start with two talks by Dr. Koenig. So the
Just start?
stage is yours.
Okay. So thank you very much. I realize I forgot to introduce myself before. So I am, as we just heard, Judith Koenig. I am a large animal surgeon and sports medicine person, faculty at the Ontario Veterinary College, University of Guelph. I forgot to say that before. So this is a clinical study where we're looking to see if we should use 10 or 20 million allogenic mesenchymal stromal cells for the treatment of synovitis in horses. And this was done with one of our partnering, it's not partnering, but one of our practices in the area. And Bree is also sports medicine boarded. So we did that study together, and of course with a whole group of other people that are very important to the success of this study. I am going back to osteoarthritis, and what I really like about this was very interesting to read a little bit more about osteoarthritis in people, and also a little bit shocking to hear that it's really affecting 30% of the population over 65 years of age, and is more common in women, and the older you are, the more likely it is that you will have osteoarthritis, which I thought was really awful is to hear that it has increased by 113% in the last 30 years. And if you're looking at this map of the world, the dark red is can you see the cursor? So dark red is the area where it's the most, like it's prevalent the most. And if you're looking at this, this is North America, and really the United States has a very high number of osteoarthritis in their population. And 1 out of 6 Canadians has also osteoarthritis. So that is quite significant. And the prevalence is 59% in former athletes. And we know that in horses, it's the cause of 60% of all lamenesses. But I just thought that it was quite shocking, the number of people that are affected by it, and that in North America, so in the first world really, there is a lot of osteoarthritis. And in countries that are like developing, these countries see less of it. So the question is it more diagnosed in our world, and people in developing countries suffer quietly from it, or because they don't have the same lifestyle that we have, they have less osteoarthritis? Is all possible. I've talked about this already before, that $15,000 is the cost per horse per year. That's direct and indirect, but in people it costs actually directly $11,500 a year per person affected with this disease. So we all have that in common, that synovial membrane inflammation is really underlying, or is really the first step in osteoarthritis, or is always involved in osteoarthritis, and is a big contributor to pain, produces interleukin-1 and tumor necrosis factor alpha. And with that cascade, you have that in high motion joints much more commonly than in low motion joints, and it's always present in all forms of equine osteoarthritis. You have synovitis, and this is one of my favorite diagrams by Dr. McElward. And basically, if you're looking at it here in your synovium, it produces the interleukin-1 and tumor necrosis factor alpha, and that initiates, you need those two, and they initiate the whole cascade of all the changes all the way into the subchondral bone that we see. And so osteoarthritis and the joint health is really a balancing act between anabolism and catabolism. And treatment should be really aimed, and that's answering the question before, that treatment should aim to promote an anabolism and inhibit the catabolism that's present in the joint. And you need that balance to have a healthy cartilage and also to repair cells. And in osteoarthritis, the catabolism is favored. And that's why, again, treatment is really important, that is disease modifying and trying to inhibit that catabolism. So the stem cells are perhaps acting that way, that they help to inhibit the catabolism or stimulate the, stimulate the anabolism, so we don't really know. I've shown you this slide before. Basically, this is the actions that we are hoping that one of these mechanisms is what works in osteoarthritis. And our previous work was with single source cord blood stem cells, and now we have set out to use pooled stem cells from multiple donors. So we needed to do a safety study prior to the clinical trial, and our hypothesis was that pooled cord blood mesenchymal stromal cells in cryomedia are safe to be used in the fetlock of horses. So we set out to compare the safety of a single donor stem cells with pooled stem cells in cryomedia in normal fetlock joints. And this is just an overview of the study design. Basically, this is a 14-week clinical trial where the horses, they are relatively healthy, as sound as horses in the research herd are. And these horses are treated, 3 horses we used for that, and we used in one fetlock pooled stem cells, 20 million, and in the other we used single source stem cells. In the other fetlock, also 20 million. And we assessed them frequently the first 3 days, initially every few hours, where we really looked for joint diffusion, the temperature of the joint. We looked, of course, at the baseline synovial fluid and compared it afterwards. And we did frequent just soundness checks, but did full lameness exams at the time points indicated here in gray. And basically after 60 days, the horses, we injected them again and evaluated the same as I just said in the long run. So after 14 weeks, they had their last assessment. And we showed that there was no significant difference really between the injection of a single donor and pooled donor stem cells. There wasn't an increase in lameness. However, there was a mild transient increase in the joint diffusion and heat following the pooled donor stem cell injections. But it usually, the first injection, it was very mild. And really the next, after 24 hours we saw it and then it went away. After the second injection we got a little bit more effusion and it lasted a little bit longer, and only the second time did we get a mild increase of the total nucleated cell count and the total protein in the synovial fluid. But again, it was a week later, the joint fluid didn't show any abnormalities. We felt relatively good to use them, and we felt that repeat intra-articular injection of the pooled donor stem cells in cryomedium is safe, but the mild transient inflammation that we had with phenylbutazone treatment, we needed to give to them to try and decrease the inflammation. And because we were setting out to inject client horses, and clients are not very fond if you inject something and the next day the horse has a swollen joint, we decided to administer the stem cells in HA instead of in the cryomedium, hoping that that would be helpful. But we did warn our clients that swelling may occur and that it is transient. So for the actual clinical study, we hypothesized that a single intra-articular treatment with pooled cord blood stem cells of fetlocks and actually carpus in horses with natural occurring osteoarthritis is safe and effective in improving the lameness. And basically, these horses were in a normal lameness workup, were identified as having fetlock or carpal osteoarthritis, and they needed to have a grade 2 or 3 out of 5 lameness. It needed to have blocked to the joint. They were excluded if they had previous intra-articular stem cell treatment, and on radiographs, if the osteoarthritis had any narrowing of the joint space, horses had to be excluded, and the referring veterinarian would work up the lameness and then call us and tell us that they had a horse that fit the inclusion criteria. In their opinion, they would send us the radiographs. We would look at the radiographs and then decide yes or no. And once the horse was determined, then we enrolled them, and they were either assigned to a 10 or a 20 million stem cell group, and it was administered in 2 milliliters of HA. And on day 0, that was our treatment day, we would evaluate their lameness, we would take joint diffusion scores, and then administer the stem cells, give them 1 systemic dose of phenylbutazone at the time of treatment, and then we would reevaluate them the following day, and then for the next 3 days, just check for effusion and swelling or any lameness, and then they were reevaluated again on week 3 and week 6, and then either at week 12 or 18, they filled out a client questionnaire, basically a satisfaction survey. And Hamid was the one that delivered with his little portable fume hood, if you want to call it that way. He delivered the cells to the farm if they didn't come to OVC, so that was always quite the appearance that he made. And as you can tell, COVID, we're all wearing masks. Lameness score, the slightly modified lameness scale from 0 to 5 is what we use. Diffusion score is the same, 0 to 4 that I showed you previously. And at the time of submitting that abstract, we had 17 horses that met the inclusion criteria enrolled. 9 horses received 10 million stem cells in HA, and the 8 20 million stem cells in HA. And 22 fetlocks and 2 intercarpal joints were injected. And the lameness pretreatment was a median of 2. And we had a significant improvement by at least 1 degree, okay, I tried again in a sentence, the 2 minutes threw me off. It had a significant improvement of a median of 1, 6 weeks after stem cell injection in both groups. And the joint infusion scores were reduced significantly 72 hours after injection. So the joint diffusion that was present at time of injection actually reduced within 72 hours, which surprised me. And also, there was no significant difference between 10 and 20 million in these horses. No overall effusion change, though, by the end of the study from the baseline lameness, and no change in lameness between the 2 doses. And what I forgot to actually write down is that in the questionnaire, we have 14 questionnaires back, and from the 14, 4 horses perform at a 4 horses perform at a same or lower level, and the other horses are all performing at the same level or better, at least perceived from the owners that they are moving better. I don't think they were competing faster, that effect we didn't see. And in conclusion, the treatment with pooled stem cells was well tolerated. It was effective in reducing both lameness and joint effusion, and comparing both doses, there is no significant difference. So in our next trial, we are setting out to only use 10 million. And I thank DECRA for providing us with the HA and EQCell for the stem cells, and our horses that are our research horses that were always there for us for our safety studies.
All right, we have time for one question. I actually have a question. I was curious about the choice of using butazone. How much were you concerned about that blocking PGE also in MSCs? And we know that PGE is an important immunomodulator. So just curious about the thought process there.
It's mostly actually, like, it's not so much that it blocks anything. It is, for me, standard of care at the time of a joint injection to give non-steroidal anti-inflammatory. And this is a treatment, I need to speak in the microphone, I was told before. And it is really something that is for clinical use, right? So I would not want to have any inflammation caused by the needle going into the joint. That is enough of a reason for me to use it. Shall I just change it myself?